Well, good evening, everybody. My name is Jens Chapman, and welcome to our May edition on a Thursday evening of the Washington State Orthopedic Association monthly re-op meetings. So it's very cool that all of you took the time and improvised to come together on a Thursday night. Today's May 27, 2021. We have an absolutely outstanding program that I'm very excited to introduce you to. And please, for all of you who are in Washington State as orthopedic surgeons, do join WSOA. Join our multiple exciting endeavors, both educationally as well as in terms of representing our specialty and musculoskeletal wellness. On that subject matter, briefly, we have three fantastic speakers, and my co-host is Dr. Michael Thrope from Bellingham, the giant from up north, and we literally cover the bandwidth of the great United States of America by going all the way out east. It's a great honor and pleasure to have Dr. Stephen Cates, professor and chairman. I'll introduce him in more detail later. Join us from Richmond, Virginia, from VCU. He's an internationally renowned expert on multiple areas in orthopedics. He's changed the game, but he's a particularly amazing research and clinician and wellness specialist. And on the far west, we have Dr. Neil Schonert in Hawaii, Kona, Hawaii, with his leisure outfit. And so we have the whole bandwidth covered, and he's going to be the middle anchor post of our lectures today, and he's going to present on how to translate research into actually better reimbursements. So without much further ado, welcome again tonight. No musical intro tonight because our guitar player, Dr. Alan Greenwald, came late. Congratulations, new father-in-law, Mazel Tov. Nice to see you. My co-host, Dr. Michael Thorpe from the great up north. We ended last month's session with a very inspirational and thought-provoking talk by a young UW resident, a female resident who talked about diversity in our workforce. And as she's entering the field and her perspectives on that. And we thought this would be a great opportunity for you who is such a mainstay of orthopedic surgery in our state and certainly in your community to reflect on retirement. And as we were talking about this, there were a couple of surprising thoughts that came up. So without much further ado, thank you, Dr. Thorpe, for taking on the role of co-host. And for a bio background, he was a UW resident. We all knew him and loved him there. He graduated in 1998. Before that, he was in medical school at the University of Iowa, and he did his undergraduate at Drake University. So Mike, take it from here. Tell us a little bit about your perspectives from Bellingham, and as a freshly retired orthopedic colleague, what surprised you?
Okay, well, thanks, Jens. Thanks, and welcome from Bellingham. Thank you for also saying I graduated residency in 1998. You just took 10 years off of my life.
1988. I said 1988.
So with that, you know, I just retired December 31st after 32 and a half years here, and I was told to show my new business card. It's not my problem anymore. So that's my new business card. Anyway, so as I think back, coming out of the UW, 1988, straight to Bellingham, it was a community of about 60,000 at that time. There's a few trends that I've noticed and noted that there's been the move from mom and pop shops to business. There's also been a move from generalists to subspecialists, and also a move from all orthopedists were in private practice to now there's a mixture here in Bellingham of private and hospital employed. So when I came, there were three groups of two. I took over a practice, hung my shingle, took out a loan, just started up, and everything was really good. There's one hospital here, a Christian hospital. We were all generalists, as I said. And then what started happening is we got one of our colleagues, Dr. Keith Mayo, to leave Harborview, and he was our first fellowship trained doc and joined us for being the traumatologist. And then in 1992, another UW resident joined me, Dr. Gary Bergman, who was a hand fellowship trained physician. 2001, we got a spine fellow to join us from UW. So we were moving towards subspecialties. About that time, we ran into the issue with the hospital over ER call, and everyone's been through that. We were unpaid. There were only 6 of us, 7 of us. We were getting killed. the time away from your private practice was very hard financially, and there was no post-trauma block, no PAs, no pay. So we approached the hospital in 2004, and we said, we need to be paid. And I consulted Dr. Brad Henley. He suggested, because we were a level 2 trauma center, we should be getting $1,500 a day. I asked around the country, it ranged from $500 to $2,500. We asked for $1,000, which was basically our daily overhead. As expected, the hospital, who had been getting free call coverage for decades, said, get back to work. And so that's when I decided, as the head of the orthopedic department, to draw a line in the sand and say, that's not going to cut it anymore. They still wouldn't budge. And so in January 2005, I took my last ER call day and moved my practice completely out of the hospital to our surgery center. Even though I was a generalist, doing just about everything. In fact, Jens, you'd be interested. Christmas Eve 1990, I used Harrington rods and rodded and stabilized and fused a thoracic lumbar fracture dislocation, not being a spine specialist, but up here, you could do that kind of stuff in hand and foot. So anyway, I left the hospital practice, and we had a surgery center, fortunately, but it was a community-owned surgery center, not our own practice's surgery center. But it allowed me to move my total joint practice there and everything else. And so that really allowed a big change in my life, my practice. I was no longer tied to the hospital, like so many of the other guys. We continued to fill Bellingham with fellowship trained people. We got a sports medicine trained person in 2010. My colleague, Dr. Bergman, retired in 2018, and we got another hand fellowship trained surgeon who did his fellowship at the UW. So we're heavily UW oriented. And then in 2020, when I retired, just before I did, we got another sports medicine fellowship trained person. And in September of 21, we will get a foot fellow. Our practice's first fellowship trained foot surgeon coming out of the UW also. He's right now in fellowship with Bruce Sanjorson and Hansen and Manushka. So Theron Udawada will be joining us. So the other trend is this private practice versus employed. And we have a collegial relationship up here, however, competitive. The hospital is a gorilla. It's the only hospital around. They are able to pay their employed docs, we believe, a much better base salary than our generalists, which we only have one now. I think our fellowship trained guys, though, because of their different business model and so forth, they're probably doing better than theirs. But the advantages that we have in private practice is we're nimble. We can adjust, we're flexible, we can make a change in a day, something we want to do. We also can add ancillaries. We have looked at ultrasound and MRI and our own PT and those kind of things. We're behind the times compared to Seattle on that, but looking now at some PT with a highly productive hand surgeon and a foot surgeon coming in. The biggest thing that our group's working on right now is getting our very own orthopedic ASC. Wish we had done that 20 years ago, but we didn't feel in this market we could take on that financial risk to do that. Also, I mentioned the trend away from, I was a mom and pop. I was a Marcus Welby in orthopedics. I sat down and talked to my patient for quite a while, examined them thoroughly, got some tests, we made a plan together, that whole thing. That's just the way we were trained. That is moving away with my younger colleagues, and they rely more on technology. They see many more patients a day than, if I saw 30 a day, that was a very busy day. They're seeing 30 in a morning. They're using PAs in a different manner than I would. I'd only use it in surgery. So that whole trend towards business is something I definitely see reflecting back at it. To help them Financially, because of not having the backing of an employer. March 1st, my group, Pacific Rim Orthopedic Surgeons, joined Proliance. So they are now a member of the big mega group up and down the I-5 corridor, which they hope will make them viable in the long term, because the pendulum, as you know, has been kind of moving away from private practice. But we are fiercely independent. We have no plans of ever being employed. And the things I like about that is, this is my business. This is my practice. I will fall on the sword for my practice. And I don't know if they can speak for themselves, but the docs who are employed, would you fall on the sword for Swedish, Jens? Would you fall on the sword for Virginia Mason? That kind of feeling. I love it. I fight for my group. Even though I'm retired, I send everybody I talk to our group, and I'm very proud of them. I feel like I left my group better than I found it, and that's a great feeling. So I'm very happy to be in retirement. A lot of people, I think, expressed concerns that when you retire, having been so busy and so on all the time, that you're going to twiddle your thumbs, maybe become depressed, things like that. And that has not happened for me. Fortunately, I have 5 children and 4 live in our town, and 8 of my 10 grandchildren are here. So I drive kids to school every morning, and I pick them up at 3, and I help my son build a house. It's the same tools I've always used. They're just not sterile, and nobody hands them to me. But life is good. I think that if I was speaking to a resident, I would just say live frugally, don't live beyond your means, so that you can retire at a decent time. Invest well. I think the best thing you can do to invest is invest in your practice, and ancillaries. I would say don't practice too long. The 60s are the decade of go, go, go. The 70s are slow, 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 and the 80s are no, no, no. So don't wait too long. So that's my message.
Well, thank you so much, and it's very heartfelt and very convincing, and you look fantastic, and have obviously done a great job. And I have to say that this generational change has me a little bit worried, but I have also great faith that there'll be somebody stepping into your shoes. But you're always a beacon, like a master concierge for the North, where I could just call you and say, who do I send this patient to? And you always knew it, and the patient always felt like they had a platinum entry card to whatever practice I sent the patient to. So your effects were amazing, and your quality of care is dramatic. Do you miss operating at all? Do you miss being with patients, or is it just all happiness? I mean, looking at your smile.
No, what's hardest is if somebody comes to me and goes, "Guy, you fixed my hip or knee 5 years ago. Now I need the other one." Oh, I would just love to fix that for them, And I still have people call me up or ask me who they should see, or I give them advice over the phone or in person if I run into them. I have to be a little careful. I don't have malpractice insurance, But I would miss that. I miss the people, the personal relationships with some patients and with my staff, both at the surgery center and the office. Fortunately, I get to see, so far I've been getting to see my office staff every week or two, because some mail still comes there and that kind of thing. But,
one more question, then we'll have to probably move on, unless Dr. Cates or Dr. Sean have another urgent question for you. In our last couple of sessions, the theme came up that an ASC is a very good weapon against these large corporations. Who should own that ASC? Is every ASC the same, or is a private practice group-owned ASC better in a competitive advantage perspective than a corporate-owned and run ASC?
Right. Well, I think economically, if you can run it yourself with your own administrator, that would be the best financially for you. In our location, it's sometimes hard to get personnel like that qualified to run the ASC, and we may have to bring in a management company, and that's what we had to do on our community-owned ASC. I mentioned Bellingham. We put together Pacific Rim Outpatient Surgery Center back in '03, and shareholders included anesthesiologists, urologists, people who don't do a lot of surgery at it. And that over time ate away at those of us who produce. I was 20% of the revenue. My group was 45% of the revenue. And yet, I got 4% of the profit because I owned 6.5 shares out of 133. So, that was nice. It was very low risk. I didn't have to put money in, and it was run for me, and I could sleep at night not worrying about it. But in retrospect, financially, we would have been much better off if we had our own center. And that's where our group is moving now, is to have a orthopedic surgery center for our group.
Yeah, Mike, this is Neil. I agree with you completely. I graduated a year after you. I hung out my own private shingle. Did that for 5 years, then built a group around me, then merged that group to ProLiance, then built our own ASC and our own MRI and our own therapy, and all of the what Mike was mentioning as the components of success in modern day practice are ancillaries in addition to your private practice. And the flexibility, the nimbleness with which you can respond to changes in your market, and the fact that you own, it's your home, and you are the owner. You're responsible for the headaches. You're also you also get the blessings and the joy. In the turn down of 2008, every single woman employed in our practice kept her job, and all of their families were maintained by our practice. We docs took a hit, but decades later, the loyalty around a corporate structure, a health system would not have done that. Yeah. The nurses would have been on the chopping block in a New York minute. And you can do that in your community, and boy, does it resonate. The ripples on that pond go way beyond your ability to see. So good on you. That sounds like a wonderful practice.
So great. Thank you, Mike, for a great perspective. Thank you for co-hosting us, and congratulations on a very successful career. And I do hope that you, at least spiritually, will stay with us for many, many years to come with your advice and insights and just winning personality. Pivoting over, a very successful practitioner, Dr. Neil Schonert, spine surgeon, UCSF grad, fellowship at Rothman, which will be a topic in the near future, I sense, coming for our state, as Rothman is looking out west to come to Washington State.
Theater near you.
Exactly. So Dr. Schonert has been very successful. He's in the South Sound area near Puyallup. He's a ProLiance surgeon. He's a spine surgery colleague. And he's always amazed me because he has somehow found the time and the drive to be active in the academic world, very much like what young Dr. Kennedy showed us several months ago in his presentation from the Mayo Clinic. So as a private practitioner, he has launched registries very successfully and taken them to maturation where they actually influence reimbursement. And many of us will have questions how you did this, Neil. So Dr. Schonert, without much further ado, please take us from here.
So I'm going to segue from Mike by saying that for those of you who are young, there are two senior surgeons on this panel who went into private practice, and both of them are smiling broadly. That smile is not shared by health system colleagues. And be mindful that in all the days of your life, the more that you smile, the greater the joy that you're living with. And so now I'm going to go into my topic.